Hello everyone, this is Marshall Riddle from MCOL, and I'd like to welcome Rong Yi, Director, Risk Adjustment and Predictive Modeling Practice, Senior Consultant at Milliman.
So with about maybe 20, 25 minutes, I would like to introduce you to how you can use predictive analytics to unveil the underlying patterns of compliance and re-enrollment, or member retention, if you will. And the goal here, remember that, is we want to understand what drives those behavior, and then also understand which of those that drives behavior, which ones are impactable, and then what we could learn from that in terms of how do we redesign the marketing and member outreach programs. And I think to break it down, there's some analytic questions. For example, the first question is, are there even patterns? Is it patterns meaning that is it consistent? Are there some historic patterns that will persist into the future time periods, or are they just more like a chaotic mess, and are they largely random, in other words? The next question is, are there some measures that are more attainable, so more easier to improve the compliance than others? And so we'll see that empirically. And the third question is, which factors influence compliance with preventive health services or avoidable utilizations, et cetera. Next slide, please. So, when we talk about predictive modeling, there usually is an analytic framework. By that we mean, what is the data that we use for modeling, and then in the next slide, which I will show later on, so what kind of modeling techniques that will be involved to get to the answer. So let's talk about the kind of data that we use in this. Actually, this is a client project. And I'm not saying that everybody had the same type of data. There are plans who are more advanced in getting other types of data. Lifestyle-based analytics, for example, would also be a great value add in these types of modeling work. So, we're using really primarily the membership and claims data. Within membership data, potentially, you could identify, in addition to age, gender, and eligibility information, there's also, which product or products, if it's for multiple years, which ones they selected. Year 1, year 2, there's some changes for some people. And then the county information, which later on we'll be able to tie to this MACVAT, which is a product that Milliman has internally. It's to measure the value add for each Medicare Advantage plan by geography. And so that's the county level. And then there's also, we know if it's longitudinal, we know which members continued or which members disconnected, discontinued. So the retention or the re-enrollment. Thinking about that, either you're looking at a plan or you're looking at an ACO organization, the same methodology applies. So are you able to keep the member? Of course, there are a lot of reasons why a member would discontinue, but for those that we know we could control for, what are the main drivers for that? And then from the membership data, actually in combination with the claims data, we will also be able to identify whether members are, institutional or have ESRD or special needs status. So these are good indicators, from a modeling perspective. This information tells us a lot about the individual in terms of their functional status and how well, physically they are able to take care of themselves, and how much do they on average they would be expected to have an encounter with the healthcare system. ESRD and special needs plans are probably a lot more frequent users than the other types. And under claims data, so will we certainly, I think, for any health plan or even going beyond Medicare, these are the diagnostic information, the procedure codes and the drug codes, et cetera. So they would give us an indication of the presence of medical conditions, the severity of them, as well as this risk score. We use the Medicare risk adjustment risk scores, and there are a number of competing methodologies to come up with a risk score. So I think they're pretty close. So I think using a Medicare risk adjustment score is good enough for our purposes. And from claims data, we'd also be able to construct, who's the denominator, who meet the criteria to be, to be, say, eligible for a preventive service, but then who complied with it and who didn't. So, and if we had this view of members longitudinally, we actually could break things into sections, break up the members into different segments. The consistent users, meaning that they had used the services consistently year after year after year. And then the inconsistent ones would be, 1 year yes, 1 year no, and so on. And then also going to be non-users. And the way to segment it actually helps a lot in understanding the behavioral pattern. And then we also have utilization, for which, some of those will become our, what we call the outcome variables or the predicted variables that we were interested in. For example, if we're interested in readmissions, ambulatory care sensitive readmissions, or ER visits, those will be constructed from the claims data. And then finally, I mentioned earlier, this data element that we had used is called Medicare Advantage Value Add. MACVAD, I forgot the T, what it stands for. And so what it does basically is that for each plan within the county, so our colleagues had developed actually two types of measures. For each plan, we would know what is the value add. The value add basically is that they applied a standard a Medicare fee schedule, and then using the plan design information to come up with an expected benefit, and then subtract out the premiums paid. So that would be the value add. And with that, then we're able to rank the plans by geography, and thinking that that would be perhaps a good contributor or a factor to determine the re-enrollment behavior. Okay, next slide, please. So now, in terms of modeling, again, the outcome we're trying to predict would be yes and no compliance, compliance with the preventive services for this year, based on the information that we observed several years prior. So that is the yes and no, more like a binary outcome. And then there's another binary outcome that we're predicting, which is retention, membership retention or re-enrollment, year 1, year 2, again, or actually more than year 1. The prediction is focusing on whether members are more likely to re-enroll in the next year based on the information that we observed in the past years. And the third one is more on the utilization, but utilization here in the context of quality as well. So because MSSP measures that, as well as Medicare Stars. And the techniques here, I can be more, if you're interested, I could certainly be happy to speak to you more about that. It's basically using multiple stages of combinations of linear and nonlinear regressions. So nonlinear, for example, we tried when we're modeling the binary outcomes, yes and no compliance, or yes and no re-enrolled, and we tried logistic regressions, for example, and for the avoidable ER visits and hospitalizations. So those are actually counts. So they're not binary, and then we use discrete modeling. So what we are not controlling for, I think, is it becomes pretty apparent to a lot of you, I would imagine, that information such as provider characteristics, the specialty or the language they speak, the years of practice and experience, or special affiliations with other, provider organizations or hospitals. So those aren't even captured in our data, but potentially they could affect the cost, utilization, the compliance. And we're also not accounting for the member level. There are characteristics we're not accounting for. For example, the socioeconomic factors, again, I think is probably a lot more important in Medicaid than in commercial and Medicare. That if members somehow, it's probably relating to education level or relating to language barriers, they just use healthcare systems very differently. They have a very different characteristic for that. So the question here is, well, if we didn't have that, how well, knowing that it's got so many limitations and potentially how much information are we still able to obtain from the model? So, which, in other words, how big of a grain of salt do we need to take when we're interpreting the results? I think you have to use a lot of judgments and see if that makes sense to you, and the results when they come out, if that makes sense to you, or if the results make sense to the client and you in combination. So let's take a look at some of the main findings we saw here. When we're trying to understand what's driving compliance, what's driving re-enrollment, retention, we saw a very strong behavioral pattern, meaning that almost the single most important factor in this year's compliance is whether whether the member was compliant or not in the previous years. So remember that going back a couple of slides, we looked at members, whether they're consistent users or inconsistent users or non-users. We just saw that the users this year are also users the next year. So that actually shows that, if it's so consistent, it becomes a very big challenge to influence their behavior, and because it's sort of got a huge inertia. And in other words, if you're thinking about rewarding members to be more compliant, so by offering coupons or by offering some other incentives, they may or may not be effective because of this. And it also suggests that when you're doing your member outreach, maybe you want to be more targeted. You want it definitely to be more targeted on those who weren't consistent, who weren't even using the systems. Try to influence them more rather than spending the money more generally on general communications and general outreach. Next slide, please. So just to validate what I was describing previously about this strong behavioral pattern, you can see that, again, this is some data that we have from Medicare for multiple years. We saw that if we look at these lists of, these preventive services, we look at, say, annual physical and screening and blood work, vaccinations and so on. We saw that it's pretty consistent year after year after year for a continuously enrolled population. Okay, so and of course, for some of these services, again, remember that we use claims data. So a lot of these flu shots or pneumonia, these things aren't really captured fully in claims. And it's possible that members could have gone to a CVS or Walgreens or Costco even to get their vaccinations. Or in the case of colon cancer screening or breast cancer screening, those aren't recommended for everybody every year. So it's possible that we might have leakages in the data, and that's why they're underreported. So in other words, if we develop the model to estimate who are more likely to be compliant with flu shots or colonoscopy, the results aren't going to be that meaningful because we'll call it the observed dependent variable is just seriously underreported.
You have been listening to a presentation for the Predictive Modeling Summit 2012 from Milliman's Rong.